as also as much viable retinal tissue as possible by injecting anti-VEGF and maybe re-injecting it a second or a third time. If you see a response to treatment and you see the physiological vasculature growing out into the periphery, and then you see a reactivation a few weeks later, then you can re-inject and gain some more ground by letting the vessels grow out further into the periphery. But in these eyes, I do agree with the investigator here from India that at some point you often have to laser these eyes on top of anti-VEGF. But I personally would not do it at the same time. I would do a delayed laser therapy then after anti-VEGF if possible. Because in my view, you might just add to the side effects of both treatments. You break down the blood-retinal barrier if you do laser treatment, and you have more of your drug leaking out in the circulation. And Neil, maybe you can comment on possible side effects of anti-VEGF treatment on the systemic part of that infant that we as ophthalmologists might sometimes neglect if we just look at the eye.
Yes, I think one of the initial things that worried us greatly about the first large trial of anti-VEGF treatment was that there was no real attempt to look at what the effect of reducing VEGF levels systemically on the rest of the baby's development, and that's something that's very much part of Rainbow. We worry about this because VEGF is a critical hormone in helping vascularize lungs and other tissues, which all develop suddenly as the IGF levels come up at around 30-31 weeks. And so anything that is likely to interfere with that might have lifelong consequences for the child. One of the reassuring things we saw in Rainbow, which is in the paper, is that the suppression of VEGF that's been seen with other preparations didn't seem to occur, and was the same in the laser arm as it was in the ranibizumab arms. So I think that's moderately reassuring, but of course, as part of the 5-year follow-up study that we're doing as part of this randomized trial, we are very much looking at neurodevelopment, growth, respiratory development, etc., to see whether we can identify any effects on the child as he grows up.
Maria, here's a follow-up question that came in when you mentioned that the vitreous might be involved in APROP, and the question is, how do you know if the vitreous is involved in APROP?
You can see it. You see that traction in the demarcation line. You can see perfectly where the vitreous is pulling the retina out of it is coming towards to the central part. In APROP, sometimes they are more aggressive for some reason in countries like India or Mexico due to the oxygen. And if the vitreous is involved, we perform a vitrectomy, but APROP is different in some countries because of the involvement of the oxygen. And you can see it. It's like a thick membrane coming out of the demarcation line.
It's basically signs of tractional, impeding detachment.
It's very quickly evolving to a stage 4.
Yeah.
And it's in a really fast manner. The posterior aggressive ROP is a little bit different depending in the countries and the oxygen management in each country.
I think oxygen
is more severe.
I think oxygen is a topic we haven't maybe covered to the extent we should. And Neil, I know you have been involved in all these large oxygen trials, and that's actually also one of the questions that we have here. What is the right and what is the wrong oxygen treatment for these infants?
The right oxygen is when the baby needs it, and the wrong oxygen is when he doesn't. It's quite simple. But, in fact, the great thing about the NEOPROM collaboration, which is a collaboration of 5 international trials, was it identified that we have a target, the saturation levels that we can aim for. and we try to keep the child within those levels, and we monitor saturations very, very carefully with limits and alarms on the saturation monitors to make sure it doesn't swing wildly. We know that if oxygen levels swing wildly or they go very high and off the scale, that does promote retinopathy very, very effectively. And so it's the careful and appropriate management of oxygen that is critical, and training programs to get neonatal staff to do this effectively and efficiently are really very, very important in neonatal systems. So what we're doing currently is thinking very much about whether we need further trials to tell us when we can relax the oxygen criteria. Is it critical that we keep it lower to start with and let it drift up a little bit as the child gets better, etc., etc. There are quite a lot of unknowns here. But these trials are not easy to do. They're expensive and difficult.
Mm. And Maria, circling back to the treatment situation and the immediate follow-up period, when you have an eye, well, most of the times you have two eyes that need treatment roughly around the same time. Do you recommend treating them at the same time, or do you have a time interval between treating the first and the second eye?
We treat them at the same time, but we treat them as if they were two eyes of two different persons. So we do one injection, and then we remove everything. We clean the urine and everything, and then we wash again hands. We do all the protocol to treat the second eye, the fellow eye, and we perform it in the same day because, as we know, ROP is a disease that is really fast the way it advances. So we don't have much time to schedule one treatment and then the fellow eye.
And also, if you delay the treatment of the second eye, you would need a second round of anesthesia, depending on or sedation, depending on what treatment you give. We do the same. We treat at the same time both eyes, of course, taking measures to make sure that we have all the hygienic standards for each injection. And Neil, for you, is that the same in the UK at your hospital?
Yes, absolutely.
Okay, we have a lot more questions, but unfortunately we don't have more time. So at this point, I would like to thank again everybody for your participation and for your interest in this important topic. And I would now like to leave you with a few concluding remarks and take-home messages from the program. Thank you.
Thank you.
And we are clear.
Okay, thank you.
Great.
Wow. Great.
So to conclude this webinar, these are our overall conclusions or take-home messages for today. ROP is one of the common causes of avoidable blindness in children, and annually 28,300 to 45,600 infants worldwide are diagnosed with irreversible visual impairment from ROP. Prevention is at the core of neonatal intensive care, and careful management of supplemental oxygen therapy, screening, and timely referrals are key clinical considerations. In the Rainbow study, we learned that a treatment success rate of 80% can be achieved with ranibizumab 0.2 milligram versus 66% with laser therapy, and ranibizumab 0.2 milligram was well tolerated in these patients in the Rainbow study. Rainbow is the first study to report pharmacokinetics and systemic VEGF data. The results of the 5-year follow-up study are expected by 2022. And ranibizumab is now the first anti-VEGF therapy to be approved for retinopathy of prematurity. I now thank Professor Marlow and Professor Martinez for being here and for the insightful discussion we had on ROP and on anti-VEGF therapy. I would like to conclude this webinar by thanking you for your attention and for your interest in ROP. Thank you.